We are now using UP Manila Livestream, FB Live at Aging Webinars, and YouTube Live at Aging Webinars channel. If you are encountering problems in internet connectivity, kindly refresh the page. For UP Manila Livestream, kindly turn up the volume using the audio icon. For other problems, please refer to the downloadable guide at the bottom of the Livestream window. The webinar lecture will run for 20 to 30 minutes, followed by a question and answer portion. Ask questions or comment by typing into the UP Manila Livestream Q&A box on the right lower corner of your screen, or type into the comments box in FB Live or YouTube Live. A link to an online evaluation form will be sent to your registered email addresses 2 days after the confirmation email is sent after the webinar. Please answer the online evaluation form to receive your certificate in your registered email inbox around 2 to 4 weeks after the webinar, depending on the number of participants and CPD unit approval. The webinar will begin in 10 minutes. Please stand by. Welcome to today's webinar. This is part of a year-long medical webinar series on aging and longevity, an initiative of the Mu Sigma Phi sorority in celebration of its 85th year, in cooperation with the UP College of Medicine, the UP Medical Foundation, and the Mu Sigma Phi Foundation. The beneficiary for this project is the National Institutes of Health Institute on Aging. This webinar series runs every second and last Friday from January to November 2019 and delivers interactive medical lectures by prominent specialists here and abroad on common medical conditions in the geriatric population. The webinars are free and open to all physicians, healthcare professionals, and medical and allied medical students. CPD units for MDs, nurses, and pharmacists will be provided. Registration is free. If you have pre-registered, you only need to sign in for attendance check. Otherwise, please register on-site. Just click on the links for today's webinar at the bottom of the UPM livestream window or in the description box of FB Live or YouTube Live. This is an important step that you need to do to have your attendance recorded and to receive the link to the evaluation form. Once you sign in for attendance, the post-webinar confirmation email will be sent within 12 to 24 hours and not immediately. To ensure that you receive your certificates in your inbox, please be reminded of the following. Make sure that your details are complete and spelled correctly, especially your names and registered email addresses. Please do not abbreviate. Example, yahoo.com into y.com. Ensure that your email inbox is not full and add these email addresses flashed on your screen to your contacts. Check your spam folder, and if our emails landed there, mark them as not spam. We are now using UP Manila Livestream, FB Live at Aging Webinars, and YouTube Live at Aging Webinars channel. If you are encountering problems in internet connectivity, kindly refresh the page. For UP Manila Livestream, kindly turn up the volume using the audio icon. For other problems, please refer to the downloadable guide at the bottom of the Livestream window. The webinar lecture will run for 20 to 30 minutes, followed by a question and answer portion. Ask questions or comment by typing into the UP Manila Livestream Q&A box on the right lower corner of your screen, or type into the comments box in FB Live or YouTube Live. A link to an online evaluation form will be sent to your registered email addresses 2 days after the confirmation email is sent after the webinar. Please answer the online evaluation form to receive your certificate in your registered email inbox around 2 to 4 weeks after the webinar, depending on the number of participants and CPD unit approval. The webinar will begin in 5 minutes. Please stand by. Welcome to today's webinar. This is part of a year-long medical webinar series on aging and longevity, an initiative of the Mu Sigma Phi sorority in celebration of its 85th year, in cooperation with the UP College of Medicine, the UP Medical Foundation, and the Mu Sigma Phi Foundation. The beneficiary for this project is the National Institutes of Health Institute on Aging. This webinar series runs every second and last Friday from January to November 2019 and delivers interactive medical lectures by prominent specialists here and abroad on common medical conditions in the geriatric population. The webinars are free and open to all physicians, healthcare professionals, and medical and allied medical students. CPD units for MDs, nurses, and pharmacists will be provided. Registration is free. If you have pre-registered, you only need to sign in for attendance check. Otherwise, please register on-site. Just click on the links for today's webinar at the bottom of the UPM livestream window or in the description box of FB Live or YouTube Live. This is an important step that you need to do to have your attendance recorded and to receive the link to the evaluation form. Once you sign in for attendance, the post-webinar confirmation email will be sent within 12 to 24 hours and not immediately. To ensure that you receive your certificates in your inbox, please be reminded of the following. Make sure that your details are complete and spelled correctly, especially your names and registered email addresses. Please do not abbreviate. Example, yahoo.com into y.com. Ensure that your email inbox is not full and add these email addresses flashed on your screen to your contacts. Check your spam folder, and if our emails landed there, mark them as not spam. We are now using UP Manila Livestream, FB Live at Aging Webinars, and YouTube Live at Aging Webinars channel. If you are encountering problems in internet connectivity, kindly refresh the page. For UP Manila Livestream, kindly turn up the volume using the audio icon. For other problems, please refer to the downloadable guide at the bottom of the Livestream window. The webinar lecture will run for 20 to 30 minutes, followed by a question and answer portion. Ask questions or comment by typing into the UP Manila Livestream Q&A box on the right lower corner of your screen, or type into the comments box in FB Live or YouTube Live. A link to an online evaluation form will be sent to your registered email addresses 2 days after the confirmation email is sent after the webinar. Please answer the online evaluation form to receive your certificate in your registered email inbox around 2 to 4 weeks after the webinar, depending on the number of participants and CPD unit approval. Welcome to today's webinar. This is part of a year-long medical webinar series.
Good morning, everyone. I am Monica Therese Katin Cabral, Mu Sigma Phi Sorority Batch 2001, speaking on behalf of the Aging and Longevity Webinars team of the Mu Sigma Phi Sorority. We are streaming live from the video conference room of the UP Manila Information Management Service. Our time in Manila is now exactly 12 noon. For today's webinar, we are privileged to have a distinguished alumna of the UP College of Medicine, Class 1989. She took a residency in internal medicine from 1990 to 1993 in Mercy Hospital of Buffalo, New York, where she also served as chief resident from 1992 to 1993. She then took her fellowship in endocrinology at Beth Israel Medical Center in New York from 1993 to 1995. Passionate about research, she received a degree of Master of Science in Clinical Epidemiology from the UP College of Medicine in 2011. Currently, she's an associate professor in the UP College of Medicine Department of Astrology and the Department of Medicine Section of Endocrinology, and an active consultant in Manila Doctors Hospital and Capital Medical Center. Ladies and gentlemen, we are proud and honored to welcome Dr. Myrna Sedurante, Mu Sigma Phi Sorority, Batch 1989.
Good morning. Today, we will be discussing the challenges in managing type 2 diabetes in older adults. This webinar aims to share the 2019 guidelines on the treatment of diabetes in older adults as prepared by the Endocrine Society. This organization usually provides clinical guidelines on endocrine disorders, which most local experts follow. I am Dr. Myrna Sedurante from the UP College of Medicine, and I have no conflicting relationships pertinent to this presentation. At the end of the session, the listener should know when and how to screen the elderly for diabetes, how to prevent the disease, when to refer to the endocrinologist, how to assess the elderly diabetic so we can tailor their treatment, and our various treatment options. Why a separate guideline for older adults? First, data from the surveys by the FNRI, both in 2013 and 2018, show that there's an increasing prevalence of increased FBS with age, and it is highest here at the right side in the sixth decade. Second, the majority of diabetics at age 60 and higher have had diabetes for more than 10 years, and a significant number of them will have several complications and comorbidities. This slide has two graphs. The first shows data from the US showing at least 50 to 60% of diabetics over 60 have had diabetes for more than 10 years. That's the green line here, green part here in the bar graphs. The second graph shows the different complications increasing with age. Among the complications here, we have hyperglycemic death, amputations, end-stage kidney disease, hypoglycemia, stroke, ischemic heart disease, and CHF, among others. Those are their data. Let's take a closer look at ours. For the cardiovascular complications among older adults, let us look at this graph showing US data and this table showing Philippine data. If we compare the US data on persons greater than 65 with our 10-year duration of diabetes here at the right side of this table, we see that for angina, here the dotted lines, US rate is 10% versus 13.2% in our locale. For MI or heart attacks, it's 15% in the US and lower here, 5.3% in our setting. So that's for the cardiovascular. For the microvascular complications, US data for eye complications show non-proliferative retinopathy at 30% versus 23% here. And as for the kidney, for microalbuminuria, it's 30% in the US versus 34% here in our country. Overall, the complication rates in the US and here are quite similar. We therefore gather that the elderly already have a lot of macro and microvascular complications, making their care quite challenging, if not downright complicated. Thus, the special guidelines. Just like relationships, where you are in the "it's complicated" category, this slide highlights that type 2 diabetes in the older population occurs as a result of the complex interaction among genetic, lifestyle, and aging influences. This complexity means there's a substantial heterogeneity in the pathophysiology, clinical features, and rate of disease progression among older people. Aging decreases glucose tolerance and insulin secretion. These impairments limit the response to lifestyle-induced insulin resistance, resulting in progression to prediabetes and type 2 diabetes. Glucose toxicity from persistent hyperglycemia can worsen insulin resistance and further impair pancreatic beta cell function. Lipotoxicity may also contribute to this vicious cycle. So now, let's answer our questions one by one. First, when and how do we screen for diabetes? Well, we do an FBS or an HbA1c every 2 years. If they end up being pre-diabetic, we do an OGTT. So look here at the ADA criteria for diabetes and pre-diabetes. If they have a value less than 100, then they're all clear. Otherwise, if their value is 100 to 125, they have pre-diabetes, and then you go ahead and get an OGTT. Aside from the pre-diabetics, also do an OGTT in the following patients: those who are overweight or obese, with a first-degree relative of DM, with hypertension or cardiovascular disease, a low HDL, a high triglyceride, inactivity, and we'll look at this later, sleep apnea. So after a 2-hour OGTT, if they have a value 200 or higher, they have diabetes. Otherwise, you can have A1C of 6.5 if the machine used is calibrated using DCCT standards, or in a patient Symptomatic, with one blood sugar of 200 or greater, you have your diagnosis. Going back to sleep apnea, note that sleep apnea is an emerging health issue and is associated with the development and exacerbation of diabetes and its complications. Okay, so if they are not diabetic but are pre-diabetic, how do we prevent DM? The Diabetes Prevention Program done in the US enrolled more than 3,000 participants here in several centers and found that metformin and lifestyle were both effective in preventing DM over 4 years and even at follow-up after many years. See here the numbers, 58% reduction in diabetes with lifestyle and then 31% reduction in the incidence of diabetes with metformin. Lifestyle versus metformin, lifestyle leads the way. Lifestyle modification performed better and was more cost effective. The lifestyle group was more active and maintained a better weight. Now, question number 3. Does everybody need an endocrinologist? The answer is no. In newly diagnosed diabetics, we can work with the primary provider to provide treatment goals. But in these cases, we may play an increasing role. That is in type 1 diabetics, those with a complex regimen, 3 or more agents or those using insulin, those with recurrent episodes of hypoglycemia, and those with multiple DM complications. On to question number 4. So here are the things that we do when we assess this particular population. Now we all remember to do the general health test and the diabetes specific tests. But in addition, recommended in the geriatric population would be the tests listed in the first column. We have there the ADLs, cognition, fall risk, and frailty, among others. Let's go ahead and spend some time discussing these. First in our list here at the right-hand side, we have the ADLs. We need to assess their ADLs so that we can advise the family on their need for additional supervision or care. Inability to do the instrumental ADL, so these are sort of higher, may lead to malnutrition and poor compliance to medications. Also, the inability should trigger a detailed assessment on the presence of hypoglycemia and hyperglycemia, micro and macrovascular complications, and cognition so that these can be addressed to improve functional status. Another important assessment would be cognition here. One of the more widely used tests to detect mild dementia is the Montreal Cognitive Assessment, or the MoCA, a 30-point test which has been validated in our population. So here we call it the MoCA-P. So here you ask your patient to do all these things. Quite easy, I tried it myself. You connect the dots, ask them to make a cube, ask them to identify these animals, and then ask them to remember some words, which they will repeat here a little later. So a 30-point test and a score of 20 indicates cognitive impairment. Diabetes increases the risk for dementia due to increased vascular pathology. The harm from unrecognized cognitive impairment can thus be avoided. Test yearly if borderline and every 2 years if normal. Once you have assessed their ADLs and cognitive function, you are ready to set their HbA1c goals. Here we go. We can group our patient into group 1, group 2 with intermediate health, or group 3 with poor health. And we can do that by putting in there the ADL impairments, putting in there how their cognitive function is, and over here, we have the presence of end-stage medical conditions, cancer, ESRD, oxygen-dependent lung disease, and advanced heart failure. So the goal, depending on the status, could be anywhere from 7 to 8.5. An HbA1c of 8.5 usually translates to an FBS of 200, above which patients are symptomatic, with frequent urination, blurring of vision, poor wound healing, etc. And that's why that is our ceiling. Moving down our general assessment list, it is desirable to check for muscle wasting or sarcopenia. so that we could provide nutrition and advice on modifying their environment to prevent falls. Here, lastly, let's look at frailty. Frailty is a pre-disability condition. Allow me to read. It is a state of vulnerability to poor resolution of homeostasis following a stress and is a consequence of cumulative decline in multiple physiological systems over a lifespan. This cumulative decline erodes homeostatic reserve until relatively minor stressor events trigger disproportionate changes in health status. We need to see whether our patient is frail so that we can classify them as to whether it is appropriate for us to do invasive procedures in them or to have lesser aggressive or lesser rigid care. More frailty requires less tight glucose control. And lastly, let me just show you an example of a questionnaire to detect frailty. It takes into consideration fatigue, resistance, ambulation, illnesses, and the loss of weight. Moving on to question number 5, what are our treatment options? This guideline placed an emphasis first on the avoidance of hypoglycemia and then moved on what to do with hyperglycemia. Again, I show you this bar graph focusing on hypoglycemic episodes as one of the major DM complications. Hypoglycemia can cause serious consequences like MIs or strokes. There are several studies on intensive versus conventional diabetes control. The ACCORD study here on the left had the lowest HbA1c goal, that is 6 in the intensive group versus 7 to 7.5 in the conventional. This study was that which demonstrated increased mortality. While the A1Cs were lower, weight was higher and hypoglycemic episodes were greater. Separation of data started around year 5. There were more people on insulin and rosiglitazone in the intensive group. 2 other studies, the VADT and the advanced, did not show the same finding, but then A1C goals were not as low. The second graph is interesting. The second graph shows a U-shaped relationship between mortality and HbA1c. Higher at the extremes and best around 7.5. Question number 5. What are our treatment goals? So, we said we would avoid hypoglycemia, and now we want to avoid hyperglycemia. Okay, hyperglycemia more than 200 results in dehydration, dizziness, urinary infections, electrolyte abnormalities. Here, I have encircled the hypoglycemic deaths. So see that they're not as high as the ER hypoglycemia complications. Again, we need to individualize goals in our patients. And tools to assess glycemia would be HbA1c or finger stick monitor. Again, let me show you the targets, but you might have seen it presented in a more popular form. So this is the slide that is usually shown during presentations, and see here that if you don't have a lot of risks, your duration of disease is low, life expectancy is long, you have the absence of important comorbidities, then you go for more stringent control. But then, if you have a high-risk patient with long-standing diabetes, a short life expectancy, severe comorbidities, then please go and do less stringent control. Individualized care at all times. Having established our targets, let's go to lifestyle modifications. These are the lifestyle modifications for young and middle-aged adults, but may not be applicable for the older individuals. For nutrition, please, let's not put them on restrictive diets. Let's just limit their simple sugars, control their portions, and provide certain nutrients or foodstuffs as needed, specifically protein for those with muscle wasting, vitamin D, and fiber as patients with long-standing diabetes already have diabetic enteropathy. Now, let's move on to pharmacologic therapy. Metformin is still the first drug of choice. Okay, if the GFR is greater than 30 ml per minute and there is no gastrointestinal intolerance. Everything else is added to metformin. However, whenever there are precipitants of acute kidney injury like radiocontrast dye, nephrotoxic drugs, heart failure, surgery, or hypotension, then we can discontinue metformin temporarily. Also take note, metformin may cause vitamin B deficiency because it increases the metabolism of vitamin B. After metformin, we'll look at other agents, but the trick is stay simple, and then first check for CBDCs or CKD, and that's what we're going to do next. I know this slide is very busy, but we should all have a copy of it. As mentioned, after metformin, determine the presence of cardiovascular disease and CKD, for which SGLT2 inhibitors and GLP-1 receptor agonists are preferred. SGLT2 use can be limited by lower GFRs. A GFR of 45 or 60 will limit you depending on the agent. Watch out for weight loss, dehydration, or fungal infections with SGLT2. Always balance the risk with the benefits. Also take note that SGLT2s can reduce progression of CKD. After that consideration, another important agent would be the DPP-4 inhibitors. They are weight neutral, do not cause hypoglycemia, and can be used even with lower GFRs. Before, it was only insulin that could be used with the lower GFRs. One of the DPP-4s can cause water retention. Lastly, we have the thiazolidinediones, which reduce cardiovascular mortality and second strokes. But again, its downside is the potential to worsen heart failure. Lastly, we have two agents which can increase fractures, the thiazolidinediones and an SGLT2 inhibitor. Download a copy of this table as the GFR limits for the different SUs are also listed here. And lastly, let us briefly go through comorbidities and complications. Treating hypertension is associated with lower all-cause mortality, cardiovascular mortality, MIs, heart failure, strokes, and CKDs. Goal BP is 140/90. Could be lower if you have CKD or previous CVD, or if you have albuminuria. Could be higher if you're in the poor health age group. Agents, go first for the ACE inhibitors. The ACE is equivalent to the ARBs for the kidney protection, but ACE is better than ARB for the heart complications. After that, you can move on to a calcium blocker and then a diuretic or a beta blocker, depending on coexisting issues. For lipids, an annual lipid profile is advised. For secondary prevention, statins reduce MI, heart failures, revascularization, stroke, mortality, and all-cause mortality. For primary prevention, statins lower MI but not stroke, CV mortality, nor all-cause mortality. Treat if LDL is greater than 70 or triglycerides greater than 500. For the meds, statins are used for almost everybody, and if insufficient, you may also use ezetimibe or this class of agents, which I think are not yet available in our locale. For high triglycerides, use fibrates or fish oil. By the way, there were other guidelines that came after this guideline showing that targeting a triglyceride level of less than 200 results in even lesser cardiovascular mortality. Moving on to CHF. As for CHF in DM, it occurs 4 times more than in non-diabetics because aside from accelerated atherosclerosis, there's also DM cardiomyopathy. These are the things that you use with caution because they increase fluid retention. The data on liraglutide is still uncertain, but SGLT2s may be beneficial because they cause a diuresis. We're getting closer to the end, looking at atherosclerosis. As with regards to atherosclerosis, DM increases the risk for stroke and PAD. So for secondary prevention, definitely it's okay to start aspirin. But for primary prevention, we have to look at our patient's risk. And why is that? Let's look at this table here, this forest plot, which shows that definitely any serious cardiovascular event is decreased with aspirin. And definitely there's major bleeding with it. So the higher the risk of your patient, the greater the need to use aspirin and use a low dose 80 to 162 milligrams. The last few slides look at the complications. Yearly, they should be checked for retinopathy, maculopathy, glaucoma, and cataracts, and their serum agents which might prevent the progression of retinopathy. And lastly, for the kidneys, do yearly urinary albumin to creatinine ratios and GFRs, but GFRs might need to be done more frequently if less than 60. And these are just the adjustment for the medications depending on the decline in kidney function. Lastly, let's go to neuropathy. Neuropathy may cause pain, motor strength loss, contractures, balance, and gait problems. So in patients with the most common chronic sensory motor distal polyneuropathy, avoid sedatives and drugs which cause orthostatic hypotension, and they may benefit from a PT or fall management program. And these are our friends that we can contact to help us with this issue. So today, we looked at all these and we learned quite a bit today, hopefully for the benefit of our patients. Here are some of the slides or references I used, and I leave you with this message. We make a living by what we get, but we make a life by what we give. So let's continue to be kind, tender-hearted, and give.
Thank you, Dr. Sedurante, for that comprehensive talk. We now have 626 viewing through FB Live. Through YouTube, we have 59 viewers. And through the UP Manila live stream, we have 21. And these are groups viewing from all over the Philippines. So the floor is now open for questions from the audience. Just type in your questions at the Q&A chat box in the right lower corner of the live stream window, or type in comments in YouTube Live or FB at Aging Webinars for Facebook Live viewers. So let's look at our questions. So while questions are coming in, Dr. Sedurante, how many would you say of the percentage of all your patients are above 60?
Oh, maybe because this is this is a specialist clinic, so probably we have a good distribution, but maybe 50 will
About
have
50%.
will be greater than 60 years old.
Okay, so it's really showing how our population is living longer, we're getting older, so we're seeing really more of this population, and it really seems very important that we need to treat these patients in a different way.
Yes.
So what is your preferred HbA1c target in this population, in general?
Sorry. So if they have a goal of, if we have 7 to 7.5, for the most part, I'm happy.
Mm-hmm.
But the more the morbidities, then we can drift up to 8.
And your ceiling would be
8.5.
8.5.
Yes.
Okay. All right. And of the medications that you mentioned, if you were to see a patient who has just developed or just been diagnosed with diabetes at this age, what is your preferred agent?
Okay, so the preferred agent is usually still metformin, because metformin has been shown to decrease cardiovascular mortality. It also decreases your weight, and it's quite cost effective.
And then what would be your add-on if you needed more?
Okay, so if the patient is heavy, then I would move to a SGLT2, because in the first 2 years of diabetes, if you can make them lose 10% of their weight, they could lose their disease. So that's why I sort of go from very cost effective to very weight loss effective, just so we could have, have that weight loss. And some of them will go into diabetes remission. There are studies now that say that as much as 35 to 40% of newly diagnosed diabetics will go into remission with a 10 to 15% weight loss. I usually go there. If they're old and we don't want them to lose weight, that's the opposite, then we could go for the DPP-4s.
How about if these patients already come to you on sulfonylurea? For example, they're on glimepiride or glibenclamide. What would you do then?
Okay, the World Health Organization came up after all these, all these societies and all these organizations started to drift away from the SUs. the World Health Organization came up with their guidelines saying that it's still, hey, don't panic, don't leave the SUs. It's still okay to use them, especially in a financially challenged environment, which is where we are. So if they're on an SU, I put them on metformin. Okay, and then after that, I go drift to the other agents. If they can't afford the DPP4s or the SGLT2s, and mainly for the males, I could go with the thiazolidinediones, and also if they have fatty liver, so they would benefit from that.
All right. So some of our questions that are coming in from Miss Brenda Singson. What are the diagnostic tests conclusive to what caused the high blood sugar? For example, whether the cause is insulin resistance or a decrease of insulin hormone by the pancreas.
Okay, well, usually we look at the patient's phenotype so that we could right away say whether we think it's really a problem of insulin resistance or it's a problem of insulin secretion. Aside from the phenotype of the patient, we look at the history. If they've had diabetes for a short or a long while, if it's a long while, then there's going to be an element of really decreased pancreatic reserve. But if it's for a short while and they're obese, then it's probably a problem with insulin resistance. So that's just for the physical exam and the history. And then for the testing, we could go for insulin levels, and that would, if they are insulin resistant, then they would have usually high insulin levels. But this is usually seen at the beginning of the disease.
Is another question here from Mavis Kisumbing. Is prediabetes the same as impaired glucose tolerance?
Yes, actually, it's the same. It's just that in our clinic, we even use the term borderline because that's what the patients understand. They don't understand what impaired fasting glucose means. That means that you're just moving from normal to type 2 diabetes. What they understand is they're almost there, but they're not there yet, borderline, or they have pre-diabetes.
Do you treat these patients with prediabetes?
Well, of course, I showed you the data on the DPP, the Diabetes Prevention Program. If I see that the patient is motivated and that there's time, I can start them on lifestyle. But if I see that they're kind of lackadaisic and that they're sort of not interested and they're really just interested in a clearance paper or something like that, I go ahead and give them some metformin.
Okay. So a common question also is, does metformin damage the kidneys?
Okay. I wonder who let go of that lie because it's a very well it's a lie that's been repeated too often. Okay, so metformin cannot be used if your GFR is less than 30, but otherwise it is a good agent. But you also have to modify the dose if your GFR is less than 45. Don't go above 1,000.
So is the elevated or increased lab results of BN-CREA an indication of CKD? This is from Al Sarte. And how do we prevent the elevation of the BUN and CREA?
Well, okay, we know that BUN is really a measure of hydration. So it's not one of the better tests to assess DM nephropathy. For DM nephropathy, creatinine is also not a good test because you would be having half of your kidney function before you see a rise in creatinine. So the best test would be micral test, the urine to albumin ratio, and a GFR.
So that answers also one of our questions from Ms. Brenda Simpson. What do you think of the micral test urinalysis? But here, I think she's asking also, what do you think of the micral test urinalysis to diagnose diabetes?
Okay, so 40% of diabetics will have complications even on diagnosis. So sometimes those diabetics, you can see them with a positive micral test, but the micral test, we do not use it to diagnose diabetes. Even the urine test, we do not use it because you would probably need to have an FBS of 180 before you will see glucose in the urine.
So another question from Tin Hamito. My late father was diagnosed with type 2 diabetes. Do I need to check my glucose level every now and then, even if my lifestyle is different from what my father had? And should I really watch what I eat and stay away from those that will trigger diabetes?
Okay, so definitely you are at risk for diabetes. Okay, first thing you should do is check your weight if your BMI is above 23. And then you can have an FBS or HbA1c every 5 years. Or if you're elderly, then you can have it every 2 years. But I think what you should do is continue with your active lifestyle.
So another question would be for those patients who are on SGLT2 inhibitors. We know that there are complications of either fungal infections, genital tract, urinary tract infections. Are we supposed to stop the medications if this happens to the patient, or do we treat and then continue with the medication?
Okay, so what happens with these SGLT2 inhibitors is they will have an increased incidence of fungal infections, but usually these infections do not keep recurring. Usually they will have it once or twice, and then somehow they don't have a repeat of it. So you can still keep them on it and then see if they will have a second infection. If so, then I think it's prudent to just stop it and try other things. And by the way, SGLT2 is for those with established uh, cardiovascular disease because there are also side effects with SGLT2. We know that osteoporosis and some say increased incidence of amputations in just one study on SGLT2, and also a rare event, diabetic ketoacidosis.
So Marilee Ponce is asking, I am taking metformin daily for PCOS and am borderline diabetic, but with average weight. I would like to ask if taking it longer will affect or damage any organs.
Okay, no, it will not affect any of your organs, and I think usually the ceiling for metformin because is about 1500. Okay, so you can still continue to use it.
From KSHMET, is it advisable to stop metformin once the FBS, fasting blood sugar, has normalized after 1 to 3 months of taking it?
I assume this that our uh, our listener has only type. Does he have only impaired fasting glucose? That's why he wants to stop it
It
after
doesn't
1 to 3 months of
specify.
taking. So, if you have been taking it for 1 to 3 months and you are pre-diabetic and you have already modified your lifestyle, you're exercising, you're doing all the right things, counting your calories, sure you can discontinue the metformin. But then if you have not done so and you have not documented that your lifestyle intervention is working, then you can continue to take it.
So in relation to that also, Ruby de los Reyes is asking, when do you titrate down the diabetes medications?
Okay. When to try to titrate? I guess the easiest time is when they have hypoglycemia. Okay, and then sometimes that's dangerous, right? So you should be trending their HbA1c. So actually, in your clinic, you should have a chart, or it should be tabulated there in your EMR. And then if you see that they are losing weight and that their HbA1c is going down, then that means they're probably doing something good. So then you could decrease. Usually, I wait until their HbA1c has dropped to 6.5 or less before I start dropping the medications. But then, if their creatinine is going high, that's why their A1C is dropping. It's because the insulin that they have, the endogenous insulin, is just staying longer in the circulation because their kidney is becoming worse. And when that happens, even if they're like 7, I start dropping down their medications because they'll probably go into hypoglycemia a lot in the coming months. And usually these patients, suddenly they have good diabetes control. They're on like 50 units of insulin, and then suddenly they could do well on what, 15, 20 units. So we should be dropping down their medicine. We
So,
should see them every 3, 4 months so that we can monitor them. In my clinic, what I do is I ask them to text in their glucose levels. So I ask them to check their glucose levels once or twice in a week, and then to text in the numbers, and I tell them we'll get back to you Friday afternoon. And that usually works well for those who are living away from my clinic.
Norland Barte is asking, is there really a type 1.5 DM? What are its predispositions and how is it treated?
I think this type help me with this meters. I think this type 1, 1.5 are those who don't have antibodies. Yeah, so it's difficult to classify them as having type 1 or type 2 diabetes. But actually, these type 1.5, some of them, they are mistakenly classified as 1.5 because you just haven't measured the right antibody. There are several antibodies, not just anti-God. There are like three or four of others which are not commercially available. That's why you get to think, oh, they don't have autoimmune diabetes. But no, we just haven't documented it properly.
I think also with the type 1.5, it's the one that's in between. So maybe they're a little older. You don't expect them to be the type 1 where they have actually absolute insulin deficiency, or with the first time you see them, they're actually requiring a lot of insulin. And then later on, you find out that they don't need it as much. So it's somewhere in between. And like Dr. said, you really need to have sometimes the right type of test. But when you see these patients, you really still have to individualize their treatment. They may need insulin, they may not. They may be able to come off it as well. Jennifer Rabilia said, for a typical Filipino living in the rural areas with diabetes, what do you usually advise on their diet? And can we advise them on about eating root crops instead of rice?
Okay, so I think this question is really going towards like the glycemic index of food. Okay, so they say that the root crops, they have a lower glycemic index compared to rice. So that just means that it's metabolized. If you have a higher glycemic index, it gets metabolized faster. That's why your glucose levels rise faster. So yes, we could advise them to have root crops, but whatever we advise them, what we do is usually we have a guide to the portions. Okay, so half cup of rice is really equivalent to 1 cup of oatmeal. It's also equivalent to a root crop, which is about the size of your fist. So those are the equivalents, and any of those can be advised. We can advise our patients. The other thing that we can give for carbohydrates would be the vegetables that are fleshy, like yung mga okra, things like that. And then we can also ask them to have some bananas, because the bananas, they usually are complex carbohydrates. So that means they are not dissolved that fast and glucose will not spike.
Mavis Kusumbing is asking, what is your opinion of serpentina?
Okay, so every time we see these uh, new natural agents, what we have to do is we have to see whether there are studies about these agents. As far as I know, there are no studies on serpentina. There are studies on turmeric. There are studies on banaba, ampalaya, luyang dilaw for diabetes, but none on serpentina. So unfortunately, we cannot recommend them at this time. We should be doing more to study these novel foodstuffs.
So on that note, what about turmeric and banaba and
Okay, so
luyang
the
dilaw?
things that I mentioned have been proven to really have glucose lowering effects. But I guess the thing about the ampalaya is don't eat the fruit, because you feel bad after, and then it's not the fruit that has the glucose lowering potential, but rather the leaves. So you boil the leaves. Okay, and the thing about the ampalaya is that the ampalaya supplements cost more than metformin. That's the unfortunate thing about it. But these are the things that we can use safely even in the rural areas.
Would you suggest that they still continue their other medications with these other supplements, the natural ones? Because some patients do tend to favor natural therapies over medication.
Well, definitely they have to monitor. That's the only way they'll see that it works for them or not. They have to be monitoring by a glucose monitor. By the way, the glucose monitors are now quite cheap, only 1,500, and you have a meter, and then each strip is only 20 pesos. So more and more our patients are getting to be more interested because the tools are easier to procure.
Dina Rositano is asking, what if a 31-year-old patient who has lupus has a triglyceride level of 189 and a random blood sugar of 98? Does the patient need to take meds to lower their triglycerides?
Okay, she's only 31 years old, and the triglyceride target is 150 to 200. So no, she does not need to take anything for her triglycerides.
Trina Ann is asking, why is it that sometimes even if you're controlling your food or watching what you eat, your blood sugar still shoots up?
Okay, I think by if that's happening to you, then maybe it would be a good idea to see a dietitian. Because sometimes we have some misconceptions about the food.
Mhm.
So we need to iron out those misconceptions.
Portion control,
Yes.
amount of calories per serving,
Mm-hmm.
etc. And Al Sarte, in relation to that, is asking, could stress be related in acquiring diabetes?
Well, the thing about stress is we can't quantitate it. So there are no studies that have been done that relate a certain degree of stress with the prevalence or the incidence of diabetes. So stress is something that we have to live with. It makes us stronger. Whether it causes diabetes, it hasn't been proven.
Hilary Selly said that knowing the glycemic index of banana is high, how many bananas could you advise for a male or a female diabetic?
Okay, three, when you go outside on the street, they sell usually three bananas for 10 pesos, I think. That's equivalent to 40 calories.
A banana.
Yeah.
Okay. So how many could you have in a day or per serving
So,
at a time?
so you know what they say about diabetics is this. They should not be different from the non-diabetics. Everything that the non-diabetic can eat, the diabetic should be able to eat, but just not that much. So for fruit serving, you can have three fruit servings, one for each meal, and one fruit serving has 40 calories. And by the way, one orange drink, the pineapple juice that you buy or the what's that? Four Seasons is 120 calories. So that takes care of your fruit servings for the day.
So would you advise patients shy away from juice also and other sugary drinks similar to that?
The thing about juice, it's better if you take it in fruit form. Why? Because you also then have the benefit of the fiber, and it doesn't suddenly raise and suddenly drop your blood sugar. So
So in relation to hypoglycemia, that low blood sugar, what is the best way to treat hypoglycemia?
okay, in the immediate in the US they have glucagon, but unfortunately we don't have that here. So what happens is that we end up, if they are still a bit awake or a little bit awake, we could give them sugar dissolved in water and then have them drink that and follow it up with a complex carbohydrate so that the glucose won't drop again. That's the only thing we can do because we don't have those other things that they have in the US.
For the ones who are not so awake, I've seen this done.
Honey?
Sugar.
Oh,
They
okay.
rub sugar on the gums just to try and see if that can at least bring the sugar up a little bit. I've seen it work in a couple of times in a rural setting. But like you said, Dr. said, if they're somewhat awake, don't try to force down liquid in a patient who's unconscious. That would be a patient that you should rush to the hospital right away. Okay. Ruby de los Reyes said that she has a patient, a 60-year-old, who was previously on insulin, but he stopped it, was lost to follow up, and then consulted, now has a normal FBS and HbA1c. He attributes this to lifestyle modification, and she's asking if we can just defer the diabetic meds in this case.
So again, we have to just test them. If their HbA1c of medications is at goal, then we can stop the medications and just continue lifestyle intervention.
And Dr. Sedurante also mentioned about the kidney function. If the patient's kidney function isn't as good anymore, they're not clearing whatever insulin they have. So he may be controlled because of actual chronic kidney disease. So maybe this patient should also have an evaluation of his kidneys.
Right.
Brenda Singson is asking about your opinion regarding apple cider tablets and their claim on lowering blood sugars in diabetes.
I think Mitos will have to help me on this one, but I have not seen, I read quite a bit, and I haven't seen any data on apple cider.
Neither have I. I've seen in patients though who do take either the apple cider vinegar itself or these tablets, they actually tend to drink a lot of water, or they use it a lot of water with it because it's very it's vinegar, so it's somewhat acidic. It bothers the stomach, and I think that the reason why their sugars are controlled is because they eat less
That's right.
because they're fuller after drinking all of that water. So that may be actually the answer to that. But I haven't seen any
But then I also
studies on that.
haven't heard from our nephrologist saying that it's detrimental, right? I haven't seen any reports on apple cider and its effect on the kidney and any complications with it.
I agree. I think it's more of if it doesn't bother your stomach and it's not causing anything um, bad in the patient, then it's okay. But again, always do this upon advice of your doctor and don't take any supplements without asking first because they can cause complications or interact with other medicines. One last question, Doctora. When you mentioned the use of metformin in the B12 deficiency, does this mean that our patients who take metformin need to be on B12 supplements as well?
Yes, I think that's the recommendation now.
All right. So thank you for all those questions.
And
And
a
again,
lot.
thank you, Dr. Sedurante, for
Yeah.
enlightening us with those answers. We would also like to acknowledge our sponsor for today's webinar, Novartis. Thank you very much. So for today's seminar, we talked about diabetes in older adults. And in summary, we would like to say that number one, there should be special considerations for older diabetes patients because of the presence of a lot of comorbidities and complications as well. Second, we should refer to an endocrinologist when the patient already has a more complicated situation, especially if the patient has had a lot of complications, including hypoglycemia. But remember that you need to individualize your therapy for these patients. And number three, hypoglycemia is very common in elderly patients, and this is the one thing that we should look out for most in this population. With that, we would like to thank Dr. Myrna Sedurante for taking time out of her busy schedule today and sharing her expertise with us. We would like to acknowledge again our sponsor for today's webinar, Novartis. And please join us again on November 15 for a talk on the role of diet and environment on aging skin by Dr. Vernon Virali-Ruel. Please also join the UP Med webinars every Wednesday. And stay tuned for some reminders.
The Aging and Longevity Medical Webinars team of the Mu Sigma Phi sorority would like to thank our partners, the UP College of Medicine, UP Medical Foundation, and the Mu Sigma Phi Foundation. We are also grateful to support from the Postgraduate Institute of Medicine, UP Manila Information Management Service, and DOST ASTI, and the PRC Board of Nursing. Most of all, we thank you, our participants, for spending your lunch hour with us. To receive your certificates of attendance, kindly answer the evaluation through the link that will be sent to your email addresses after you sign the attendance sheet for today's webinar. The certificates will then be emailed to your registered email addresses within 2 to 4 weeks. Here is a quick view of the schedule of our upcoming webinars. For more details and updates, please check our Facebook page at facebook.com/agingwebinars and our Twitter timeline at twitter.com/agingwebinars. Today's webinar recording and all webinar recordings may be viewed at YouTube at Aging Webinars channel. We are also announcing the launch of the OB Pearls book. Get your copies now. Thank you and have a great day.